The topic I've been assigned, transrectal approach to prostate biopsy, puts me a little bit on the defensive because there is currently a zeal for transperineal biopsy, a wave of enthusiasm. In preparing for this talk, I thought I should go to Campbell's, our Bible, and see what it says about prostate biopsy. And sure enough, you couldn't find a more archaic passage, because here, right in the current Campbell's Urology, it says systematic transrectal ultrasound biopsy is currently the gold standard and will remain that way indefinitely. So I took this as my own challenge. In fact, this is the same challenge that we looked at in 2009 when we first began this work. Sepsis following transrectal biopsy is a problem very well known to me, and it's what caused us to reevaluate everything some years ago. This headline dates from the European Urology meeting last month when a urologist from Norway reported a death that occurred after a transrectal prostate biopsy, and the poor man's daughter, the man who died, his daughter then became a spokesperson for this cause. The man became a martyr to this cause, and there's a lot of concern right now, as we've had, about sepsis following transrectal biopsy. The answer to this for us was to consult our local antibiogram, which is a compilation of all cultures and sensitivities done at the institution over the past year. Each year, this is updated. We did this because we, like everyone else, had a 4% incidence of quinolone-resistant E. coli sepsis that was a terrible problem. So what we did, let me just go back one second. What we did is to look at our antibiogram and determine that there was a drug that provided virtually 100% sensitivity against the coliform bacteria in healthy outpatients who are our patients for biopsy. And that drug is called ertapenem. And that was the drug we chose. And since using ertapenem a gram an hour prior to each biopsy for the past 4 or 5 years, we've had not a single septic episode out of about 2,000 biopsies that have been performed. I don't worry about sepsis any further using transrectal biopsy. I just don't think about it. And we have adopted this routine. One of these days, I fear the bugs will get smarter. But for now, it's not been an issue. So we continue to do this transrectally as a routine. So infection can be prevented. Let me repeat, not a single septic episode out of 2,000 biopsies using the preventive that we use. There are a number of reasons why I like transrectal biopsy and do not feel that I must jump on the bandwagon. The most important is that infection can be prevented. Another important indication is that patients tolerate transrectal biopsy better than they tolerate transperineal biopsy. The lateral decubitus position is a comfortable position for men, and we're doing a lot of repeat biopsies in men in active surveillance. And if they have an uncomfortable experience the first time, they're reluctant to come back. The anesthesia requirement is less, and we don't have to have sedation. There are no perineal nerves to transgress putting that needle in, so we feel the anesthesia requirement is less. The speed of the procedure is undoubtedly much faster, perhaps twice as fast as a transperineal biopsy. I have watched experts do this, and I still am certain that a transrectal fusion biopsy is a 15-minute procedure at most. I should also point out that the knowledge base of fusion biopsies has almost entirely been acquired via transrectal approach. So almost everything we know about fusion biopsies has been obtained with this kind of information, transrectal. So I want to take advantage of the knowledge base that's been built. And finally, to point out that the fusion technology for transrectal biopsies is quite mature. It's been around since around 2009, 2010. There's everything we know about fusion biopsies has been obtained via transrectal approach. Not that this won't change in the future, and should there be a randomized trial showing the advantages of transperineal biopsy, I am willing to reconsider. But for now, I am very happy with our current approach. This is a classic example of a MRI fusion biopsy. In the top row, there is a MRI shown with a T2 weighted image, a diffusion weighted image, and a dynamic contrast enhanced image. These are the three parameters in a multiparametric MRI of the prostate. This is a tumor that, let me also point out, I've chosen this case because it's an anterior tumor, which we diagnose. This is something that the transperineal crowd likes to say you can't do transrectally, but if you know where that tumor is, you can put a needle in it virtually anywhere in the prostate. So the transrectal ultrasound is performed. There's the lesion, which has been now fused into the model. We always do systematic and targeted biopsies once in someone undergoing a first biopsy so that we know where the tumor is and where the tumor is not. And then when this man had a radical prostatectomy, you can see that the finding of the tumor confirms what the MRI and biopsy suggested. And this little spot of Gleason 6 was undetected, and that's just fine with me. So I thought that in my 20 minutes this morning that I would concentrate and tell you on some of the lessons that we learned during the development of transrectal ultrasound fusion biopsy. We were asked to do this review some years ago, and I want to expand on this somewhat now. Our experience is, I think, one of the world's larger experiences. We have done about 5,000 procedures since 2009 when we first started this, about 3,200 unique patients. And this is the model we do on every first biopsy patient in a man who has an MRI visible lesion. First lesson that I learned is that you can't do it by yourself if you're going to do a good job. It's a team effort. And when we started this in 2009, I didn't know much about ultrasound. I knew a lot about ultrasound, but not about MRI. And what we did was get a team together. The fusion, there's a lot of technology involved in the fusion. Much of it's been worked out by now, but I recruited a cooperative pathologist, a cooperative radiologist. Both have become world experts in this area, and a biomedical engineer who's here at this meeting, Shyam Natarajan. We've been working together now for a long time. A startup company has come out of this. He'll tell you about that later on. And a research coordinator to keep the records. If I did one thing that was smart at the beginning, it was to keep records and to keep a database going on everything that we learned on every patient. And that's what's allowed us to learn some stuff going forward. The second most important lesson is that PIRADS rules. PIRADS, Prostate Imaging Reporting and Data System, is a internationally accepted way to interpret MRIs. It was described in this article by Dr. Weinrib from Yale. He's a radiologist, and everyone uses the PIRADS version 2, which is commonly available, and every good report should use that as a reference. This shows 3 different PIRADS examples, and the chances of finding prostate cancer vary directly with the PIRADS score. This is a 3, a 4, and a 5. In PIRADS 3, you have a small, faintly visible lesion. These are all, by the way, T2 weighted imaging. When you add you can't get a PIRADS score without the other components, which I showed, the dynamic contrast enhancement and diffusion weighted. But when we find a PIRADS 3, it's got about a 25% likelihood of finding a treatable prostate cancer there. PIRADS 4, about a 40% likelihood finding a treatable prostate cancer. And a PIRADS 5, an 80+% chance of finding prostate cancer. If we do a biopsy on a PIRADS 5 and we don't find cancer, we frequently re-biopsy that patient if the lesion has persisted down the line, because we worry about that negative biopsy. So there are many things that go into finding these cancers, but nothing is more important than rule number 2, that PIRADS rules. The third lesson that we have learned is how important the co-registration is. This is in the In the top row here, this is an accurate co-registration, and the second row is an inaccurate co-registration with the true lesion shown in green and the perceived lesion shown in red. In the accurate experience here, the yellow outline of the prostate, that is the segmentation based upon your scan, is very highly correlated with what you actually have from the MRI, and the needle goes through the true lesion, which is the same as the perceived lesion. But in the second example, notice that the segmentation is off and the lesion is shifted over. And so the operator's attention is focused on the lesion he perceived, and in this case, it's not the true lesion, and he will have a falsely negative biopsy. So co-registration is very important at the beginning of the procedure. A scan is done at the beginning of every procedure, and if you're not happy with that scan, you should repeat it before starting. This shows the three types of errors which are possible in co-registration. It can be an error in offset, an error in size, or an error in shape. So we must be, if the scan is not good, go back and repeat it. The fourth lesson is that we always do a targeted and systematic biopsy on every patient having his first biopsy. We may not repeat this subsequently depending upon MRI findings, but everybody gets a systematic biopsy and a targeted biopsy first go-around. The reason for this is that the MRI is not perfect, and lesions like this seen on the MRI may be falsely positive. And so we do biopsy the lesions, we focus on those lesions, take extra samples from them. But in this example I'm showing you, the true cancer in this patient was here on one of these systematic biopsies, and this was a negative finding on the sampling. So targeted and systematic biopsies at least once at the beginning for every patient. There are some cases where we omit biopsy comfortably, and that is those who've had a negative MRI and a low PSA density. In those patients, in that important duo, we find only a 2 or 3% chance of clinically significant prostate cancer, and in these instances, I am comfortably deferring systematic biopsy. The other time we defer systematic biopsies is in a very large prostate. Let's say more than 80, 90, 100 cc's, because it truly is a needle in a haystack taking the systematic biopsies. And then we must rely on MRI. In some of them, we've been starting using PSMA to look for cancers that are MRI negative. We'll talk about that a little bit later on. This is an example of how tracking is very important. All the white spots were the initial biopsies. Those have been removed. And in returning to this patient in active surveillance, we focus on the tracked positive biopsy sites. Tracking is the Cinderella stepchild of fusion biopsies. Everyone appreciates how important targeting is, but tracking is also a very important part of targeted prostate biopsy. It should be done routinely. The machines will do, all of the fusion machines will do this for you automatically. If you are not using this, your rep will show you how to do this. It's not a big deal. And to be able to recall the positive biopsy sites at a later study is very important. In our active surveillance study that we did published a few years ago, many of the positive biopsy sites in follow-up were only found on tracking biopsy. So please think about that. Do tracking. Many upgrades in active surveillance found only via tracking biopsy. And the last lesson that I want to tell you about is one that we've learned recently, published recently. This is published in European Urology by Wayne Brisbane a few months ago. The engineers that I work with, and you don't have to worry about this, but the lesson is that we determined is pretty clear. The engineers that I work with found a way using what's called a MATLAB algorithm to determine the distance between the MRI region of interest and any biopsy cores around it, anywhere in the prostate. And by this is done computer generated, and by doing all these distance measurements, we found that the great majority of all positive systematic cores occur in the area right around the MRI visible lesion, which is the cancer. It put it in astronomical terms. This is the umbra, and this is the penumbra. So don't forget penumbra samplings. You'll be well rewarded. And this is very important in terms of planning focal therapy, as we'll talk about a little later on. I think it's remarkable about the growth in this industry. Things are going to change for sure. I did a PubMed search a few days ago on prostate plus MRI. The growth is unbelievable. There are now over 14,000 references to this on PubMed. Much of the growth has occurred just in the past few years. It's impressive to realize that the first published picture of a prostate MRI was in 1983. Hetty Rechak, now at Memorial, published this from UC San Francisco. All you can see in this T1 image is the Foley catheter and the prostate right there. Nothing else shows. And what an amazing advance our radiology colleagues have made for us. So just in conclusion, let me say the take-home messages from today: and build a team, learn about the PIRAD score. And incidentally, if you're not able to interpret an MRI, don't worry about it. You have to rely and build a relationship with a radiologist who's going to make this a specialty. There's such inter-reader variability interpretation. You've got to trust your reader and use his result, co-register accurately, do a targeted and templating biopsy, and at least once in every patient, track the biopsy sites, and be sure and take some perilesional sampling. Neil, thank you.